is the second one of our lecture series with the subject of new normal and opportunities of post-COVID-19 world, which is joint organized by Alberta AI Edmonton and CNKI China. My name is Fang Fang, currently act as the Vice President of Events and External for Alberta AI. It's my great pleasure to be the host of today's webinar given by Professor Pierre Boulanger. The lecture will take 1 hour, consist of a 45 minutes speech and a 15-minute Q&A. So the audience can feel free to type your questions during the presentation, and we will forward the questions to the professor later.
Thank you very much. Sorry.
Now let me introduce today's speaker, Professor Pierre Boulanger, to all the audience over China and Canada online here. Dr. Boulanger accumulates more than 38 years of experience in 3D computer vision, rapid product development, and applications of virtual reality system in medical and industrial manufacturing. With the double appointment of professor at the University of Alberta's Department of Computing Science and Department of Radiology and Diagnostic Imaging. He is also on editorial boards of 2 major academic journals and sits on many international committees. His main research topics include application of AR, VR technologies to medical training, simulation, and collaborative diagnostics, and the development of new techniques for telemedicine applied to aged care facilities and remote regions, and patient-specific modeling in surgery. Dr. Boulanger is also the CTO of Nayat Lab, who is commercializing MedROAD, a healthcare platform that he will present today. So now, Pierre, please take it over, start your talk.
Thank you very much. That's a very nice introduction. So we're going to share, goes to the slides. Oops. So yeah, so my topic today in this evening for me and this afternoon, this morning for you, is to talk about next generation of health system for COVID-19 and in beyond COVID-19. I mean, basically using telemedicine now that it's become very popular because of COVID-19 to monitor people remotely. As you all know, I mean, China experienced COVID-19, Canada did too. Currently, this is latest statistics, about 11 million people have suffered from the disease, including myself. Actually, it's pretty very bad disease. And about 500,000 people just died of COVID-19. In Canada, the situation is a little bit better. We have basically about 3 million people who were tested for COVID-19. Out of that, only 150,000 were basically cases, and then many people recovered, and very fewer deaths than, let's say, United States or many countries. So, as you can see here from the curve, we are moving toward the first wave. At least is almost over, and hopefully, with more strict rules, we will not be able to go, or we will not go as United States to the second wave. So COVID-19 is characterized, and this is very important for what we're going to do in order to actually monitor COVID-19 patients. What is the difference between COVID-19 and flu or influenza? I mean, you can see here the two viruses. They look pretty much the same, except, and so one is based in some way come from the other one. And but the big difference is, of course, symptoms begins in the case of flu or influenza between 1 and 4 days. In the case of COVID-19 is 14 days, which is a little bit of a problem since let's say that you come from a trip, you got 14 days of incubation where you're not aware, and so the danger for exposing other people is much higher, and hence the faster progression of the disease. Typically, the cause is influenza virus. The first one you see here and the other one is the SARS-CoV-2 virus, which is some way much more virulent and certainly much more catchy. So one of the consequences of the COVID-19 is basically that we, in the case of the influenza, we're prepared for it. We all had influenza when we were a kid, and we have an immune system that is prepared for that. The big difference in the COVID-19 is that this is a totally brand new virus, so our immune systems has to learn to deal with it. And there are, of course, consequences to that, which is severe respiratory complications that are due to the virus, and, for example, accumulation of fluids in the lung, where we can actually then use special sensor technology to actually detect them. Unfortunately, for COVID-19, as opposed to influenza, there's no prevention. So it's the only way to deal with that is self-isolation. In the extreme case, COVID-19 will be typically detected by a test, which if it's not too severe, you could basically stay at home and then get really, really sick. I mean, as I'm experienced personally. And but if, for example, the fluid in your lung get extreme, you basically would go to the hospital, and they would first do an imaging, so basically a CT or an X-ray, looking at your lung, and then decide on the next step of therapy. It's been shown in Canada and a few other places that cortisone treatment is really good to reduce mucus accumulation. But in the extreme case, and this is where it gets really dangerous, is you end up with the need for life support, a ventilator, in order to help you to not choke to death due to the accumulated fluid in your body. COVID-19 has also all sort of side effects, I mean, high temperature, and also some effects in the sense of maybe after a month, you might have fevers and things like this. So there's a long-term effect as well. So idea is, of course, we got unprepared in some way from the healthcare system, in the sense that we typically have an healthcare system that is reactive as opposed to proactive. And then what happened is, of course, we reacted to COVID-19, and some country reacted a little bit too late. Some country reacted right away. China is a good example of reacting right away and minimizing the effect of COVID-19. So, the lack of early intervention and prevention is contributing to this illness. And the more you allow people to interact with people, because of the incubation time of 14 days, will make the COVID-19 spread even further. So in response to that challenge in control of the spread of COVID-19, one of the things that we want to do is is to detect people to have COVID-19. And for example, if you come from an airplane, we would like to be able to order you to go to a quarantine of 14 days since in the incubation period, and possibly do more than that. I mean, and we're going to show you in a moment that we can actually give you a little sensor where we can monitor you for the 14-day period, and using machine learning to look at your vital sign and being able to determine what is the evolution of the COVID-19. So one of the ways to track COVID-19 is to establish an electronic recording and tracking system that allow you to monitor what people are responding to COVID-19 infection, and in a 24/7 period. And the other things, of course, is to be able to centralize some of this information, centralize in a private form, so that maybe you don't identify, but certainly for immunologists to be able to determine who has COVID-19, and also how to determine, more importantly, how to determine when should you go to the hospital if you ever had the bad luck of getting COVID-19. So in about the last 6 years, part of the Cisco chair in healthcare, we've been developing a solution that was actually initially designed for monitoring older population, and as well as population that are in remote regions. In Canada, we have a lot of regions that are very remote, and we developed a special system that allow you to create something called a virtual clinic. And the virtual concept of virtual clinic is that we can actually capture, you go to the clinic, you capture with sensing, evidence-based medicine, blood pressure, for example, temperature, O2, blood analysis, and so on. And all this information gets sent to the cloud, and associated with that, we can either present that with some video conferencing to the GP, or, and hence the notion of virtual clinic, but also we can also take this information and send it to a machine learning agent that would actually look at the data and then do something what we call patient-specific model, where we actually can track patient health through an evolution of their vital signs. So the idea of that MedROAD is to basically create individualized information and empower patient to control their data and, of course, get quicker response. One of the key advantage of a virtual clinic is you could be, for example, at home, and if you're really sick or your kids are sick, you can actually talk to the doctor. That many people have that, and there's a system in Canada. I'm sure there are a system in China for this. What we've added to it is the ability to measure things and really create something that will resemble what you would actually have in a clinic if you go and see your doctor. So the way to do that is we have integrated multiple medical grade sensors, ranging from thermometer, O2, to breathing sensors, to blood sensors, to ultrasound, and so on. All those sensors get basically transmitted to to a cell phone, or in a special hub. We have also a special hub that allow you to transmit this information and get transmitted in a secure way, encrypted, and also medical grade encryption. We're using HL7 FIR, and to a server. And then what will happen is the clinician can connect to you. So patient can want to just do measurement and upload that, maybe talk to the doctor maybe a week later, or if it's an emergency, talk directly to the doctor. And then basically the clinician can go into a web portal. He'll be able to visualize the information and directly talk to the patient, or the nurse is taking care of the patient, in order to do more measurement. To give you an idea, what we can do, for example, the nurse can measure with a stethoscope the patient's heart, the patient's heart noise or sound can be digitized and transmitted to the cloud. And then afterward, the clinician can download into his own stethoscope, electronic stethoscope, the heart noise, and then basically be able to hear remotely the patient's heart, as it basically allow you to do some form of diagnosis. So the idea is, and initially that was the whole cost of healthcare. I mean, going away from just building big hospital and in big cities, and basically allowing to bring the equivalent of big hospital service into smaller region. So the idea was to virtualize the service to allow you cost reduction, better access, and focus on prevention as opposed to doing emergency cases. Typically, for example, to give you an idea, if you have a person who is suffer from cardiac condition, end up with COVID-19, the low oxygen count in due to the lung problem will maybe trigger some cardiac conditions. And the idea is that if you're going to have a heart attack, it's always better to know ahead of time and then basically decide whether if you're going to go into a hospital or stay at home and be monitored remotely because you might be in a situation where you're not able to be transported. So the system is Android-based. It allows you to get information from Bluetooth devices. And we chose that technology because we didn't want to build devices. We just wanted to integrate a whole pile of devices. And you could find, I mean, the trend today is many manufacturer devices tend to have their own cloud solution, but none of them actually will integrate all this information in order to be compatible with machine learning, where basically we want to have the data and the time series produced by that and be able to use machine learning algorithms to detect anomaly. So the web page, so that will allow you, the clinician, to be able to remotely connect to anything. I mean, the web technology, and then basically the server who actually allow you to collect that data. So here's an example here of a typical MedROAD session. Unfortunately, I don't think you can hear the sound, but typically when you connect to the system, the clinician can connect to the patient. So you can see the patient, so you can see his physical condition, and then you can actually have all the information, all the information that is associated with the patient with that. So it's really, the idea is really to create this integration, as opposed to what you find in the market currently, which is, like I said, a separation, or everybody produce their own sensor and put that together. We're doing the opposite. We're collecting information. And so part of the video conferencing, we're using something that, I mean, we could have used Zoom. We use, for example, WebRTC or WebEx in order to do that. So one thing that allow us to sample the information is allow to filter patient data, which allow to reduce the burden on frontline workers. So for example, if we give to a cardiac patient a special heart monitoring sensor that is recording for 48 hours the heart of the patient, we don't want the doctor to be able to have to look at 48 hours of ECG. I mean, that would be unacceptable. So what we have is, of course, use, again, machine learning to detect anomalies and just highlight where things are. Our approach is we don't believe AI can actually be the diagnostic for all sort of reasons. I mean, the doctor is still in control, but what we think is AI can certainly help the doctor to do a better job at monitoring patients. So here's some example of some of the sensors we use. So I've put some very simple sensors here to give you an idea of what we can do with them and the different scenarios that we've been experimenting and still experimenting with. One is basically a low-cost sensor, is $50, which allow you to measure O2, pulse rate intensity, and temperature. And this one, we're going to use it for COVID-19 quarantine monitoring. Another one, which is a simple watch, actually it's manufactured in China, which is allow you to measure some sort of blood pressure. It's not medical grade, but it's good enough for certain, not hypertension patient, but certainly for determining if the blood pressure is increasing. Heart rate, pulse oximetry, temperature, and sleep monitoring, another $40. If you're a patient with more higher danger or frailty that we call in medicine, then we have other device that we use. One is a more portable device called the QardioMD, which gives you a 3D ECG and temperature and breathing. And the best one, which is Astroskin, which is actually built in Montreal, which was actually designed for astronauts, to monitor astronauts in the space station. So let's take some scenarios of monitoring, and then we'll see how after that, how we actually use machine learning to detect those. So let's assume that you come from an uncertain contaminated environment, maybe the famous cruise ship, who seem to have produced a good incubation environment for COVID-19. So the family comes home and they basically are staying at home or at least for 14 days in isolation in order to determine if they do have COVID-19. What possibility in what we're studying is to give them a $50 pulse oximeter with temperature, where all the members of the family get measured maybe 2 or 3 times a day for these parameters. This information automatically, the people have to do nothing. They automatically send this information to the MedROAD server, and then there's data analytics that actually determine that. What the server will give you is back into your cell phone. Basically, if you're free to go, stay over for a longer time because you might have COVID-19 or a mild version, or you need to go to the hospital, but also be able to send in an anonymized way if you have actually done your 14-day quarantine, and also if you were infected with COVID-19. It's much cheaper than some of those blood tests, and also much more available. It's, for example, people coming out of airplane or boat could be given these simple sensors that can allow you to monitor, and the software. So it's basically an app that you can download on your cell phone. Second one is a watch. And so we were thinking of how can we monitor COVID-19 when you think you're okay, you're going to work, and you want to be monitored. In a sense, employers want to monitor, and everybody want to be monitored to know if by doing your work you catch up with COVID-19. So we're using this very simple watch. It's basically a $40 watch, which allow you to give you blood pressure, not medical grade again, heart rate, and again, the information gets sent to the MedROAD server, and basically some of that might not be sent to, it could be sent, for example, to your employer or to your own self, where you have no sign or an evolution. So for example, your temperature might be going up, your O2 level might be going down, which, I mean, you would reflect as feeling sick, but it will actually be characteristics of the COVID-19 problem. So once we got all this information, we can integrate all this information using spatial Bayesian network system, where we basically take all the information from the vital sign that we measure. We also have information from self-reported patient symptoms, and of course behaviors. So use the mask, wash hands, respect distancing, the recent travel, exposed to infected environment. And of course, associated with that, some medical history. Are you, for example, a cardiac patient, a COPD patient, or basically, you will see a little bit later on, there's all sort of condition that makes COVID-19 more probable to be dangerous. There's also something called contact tracing that have been tried in Alberta. It's not been very popular for also the reason, the fear of, and I'll talk a little bit about that a bit later on, but it's, so the idea is that if you met someone who has COVID-19 with Bluetooth, you can actually share this information with the other cell phone, and then you can actually tell that you were actually connected with someone who may have Bluetooth, basically COVID-19. The advantage of using Bayesian network, as you might not know, is that we can actually do something very important into our system, which is the ability to transform this information into patient diagnostic in human language. Very important in a sense that we want the doctor to be on the control seat, and we have to be able to have the system being able to explain why the system thinks that you do have COVID-19. So coming back to contact tracing, the idea is, of course, is this connection, and Alberta had a called the AB Trace Together app, which allow you to do contact tracing. The advantage of that is, of course, the advantage is that if you are in contact with someone who close to someone who had COVID-19, it would increase your probability of being exposed, and then basically give you some warning about The problem with that is, of course, a lot of people got a bit paranoid by being tracked this way, but also more importantly is, yeah, it's a good idea in some way, I mean, to track this especially, but it still doesn't give you how certain you are about the COVID-19 that you have, or if you were exposed to COVID-19. So it's, in some way, it's not sufficient, if you like, to give you this information. The only way to determine you're sufficient is to go for a blood test. There were some free blood tests in Alberta where then this would get reported to the app, and then of course you can trace back how many people you met and you getting the possibility of having COVID-19. Don't forget, COVID-19 has a 14-day incubation, so what you want to do is to warn patients that not to stay isolated if they've been in contact with people who had COVID-19. So the Bayesian framework is the following. So basically what we have is background risk factors. So for example, age, underlying medical condition, sex, obesity have an effect, and then basically determine the condition. And then the idea is that the system will then determine what is your probability of having COVID-19, either severe, mild, asymptomatic, or none. We can also get information from the tracking information and also from the test, and then all this information get to there. If you do have COVID-19, then we can actually add extra information called symptoms. And these symptoms, for example, that can be, some symptoms are reported: coughing, fatigue, subtrum production, so fluid production, chills, dysthymia, and myalgia. But the two ones that we thought there was an opportunity to use is O2 saturation and body temperature, which are determinant of fevers. And then the idea is to determine from that, do you or do you not have COVID-19? You may have influenza associated with it. So each of those systems produce their own probabilities, and there's a network of probabilities that get accumulated in order to actually determine what is the actual probability of you having COVID-19, and also determining at what severity level your COVID-19 is. So this information can then be sent, and it's automated. It will basically, once we get in the case, for example, of quarantine, we would get the sensing, your family gets sensed, or you fill up a form to get the information required for your health and so on, and you're reporting your symptom, and the system will tell you, well, you may unfortunately have a COVID-19, or you may just have influenza, or you might have to be in a case where you do have to go to the hospital. So this is for a patient that will start to have COVID-19. Tracking using sensors and AI in order to actually determine what is the probability of having COVID-19. The other one is to monitor acute patient during COVID-19. COVID-19 is quite a killer, as you can see here, with people with heart disease or chronic respiratory disease or high blood pressure have a higher chance of getting killed by COVID-19 than people with full health. One that we focus with the Mazinkowski Heart Institute is the heart disease one, where there's a chance, if you have a heart disease, you have a chance of 10% chance of getting, possibly of dying. For a simple reason that if your lung get infected, your O2 will go down, and your heart will have to pump more in order to get more O2 in your body. And of course, as your heart pumps more, you would have to certainly tax your heart much more. So in order to track that, we have many sensors. One is a so-called VivaLink, which is a simple patch that you can wear on your chest, and it will give you ECG pulse rotary. It's actually send the data to the cloud, And basically, but the problem with that particular patch is that it's only a one lead ECG. So if you give that to a patient, yes, you can track, for example, atrial fibrillation, so the start of the heart not functioning properly, but certainly not sufficient to give you a diagnostic of heart condition. So for very acute patients, so patients that were in an emergency ward and need to go home, we've actually also adapted to the MedROAD system a vest that was actually developed for here is astronaut David Saint-Germain, which is basically in the space station here. And what happened is then what you have is the complete suite of telemonitored O2, you have blood pressure, you have heart, and more importantly, 3-lead ECG heart, which is the standard medical measurement, skin temperature, breathing, upper chest breathing, lower chest breathing, and activity level. So it's same information you would get into an emergency ward in order to do that. All that information to our system gets sent to the cloud, and of course, this needs to be measured. If you, but it is more invasive. You have to wear this vest here, and it's, of course, the cost of it is much more. I mean, it's typical $5,000 to $6,000 Canadian to actually put a vest like this. But if someone is really in very acute condition, or that certainly is a worth investment. Another system that improved what this little patch we had is basically the CardioMD, which is basically give you 3-lead ECG and all the other parameters that are required for that. So once we got this information, we can actually monitor the acute patient system. So respiratory parameters, vital sign parameters, sleep quality, and we'll talk about that in a moment, the neural network analyzer for ECG, and then of course, medical history. All this information get combined in a Bayesian network, and then the system can issue alarms, system alarm with conditions, and of course, safe conditions associated with that. So the big difference here is that we need to analyze the ECG. So ECG is, for those of you who don't know what it is basically electrode that measure your heart on the surface of your body. Typically, the minimum that you need in order to be medically grade is 3 of them. And then what we can do is look at the QRST complex. So QRST complex is the shape of the heart. So it's basically represent how the heart is beating. So there's absorb the blood, basically, and then the blood valve open, and it inject the blood into the oxygenated blood into the direction of non-oxygenated blood. And then there's a characteristic shape of these ECG that is determined, that will actually determine if your pump, if you like, is working properly. So there's basically many type of things that we need to classify from that. I mean, to right bundle branch block, all the way down to fusion of pace and normal block. So a lot of possibilities where they can be determined. So typically, cardiologists will look at this information and do that. The problem is, if you go to your cardiologist, and part of MedROAD as well, we have a 12-lead ECG, which is the standard. And then we can record it, and then the cardiologist will remote look at it and then determine if you have a cardiac condition. The problem with that is the day you go for your cardiac measurement, it might turn out that you're feeling okay, your heart is working good, but you might go into your parking lot and have a massive heart attack. So heart is a bit like when you monitor your car engine, you want to monitor it continuously in order to actually determine if you may have, in some condition, heart problem. So typically in heart system, we have basically the raw ECG that get measured, and frequently we have a problem which is called motion wonder that we compensate. And then we can filter it to get basically a flat representation of the ECG. And then we have to detect each beat and then classify or detect where are the QRST complex. And that shape here will determine how healthy is your heart. So we have a special segmentation algorithm that actually extract the QRST complex. And then from that, we can feed that as a classifier to a neural network, or in our case, a residual neural network, where we can actually determine normal signal or problem signal, and then also classify the type of problem that you have. So here's a typical example of the algorithm we developed. So we have our normal ECG here. We first do a spectrogram of the ECG, a bit like voice recognition. And then we actually look at the spectrogram shape and feed that to something called a redundant neural network, which is simply a normal neural network. I mean, for those of you who know neural network, we have an input, we have a weights, an activation function, and a weight layer, and then we can classify patterns. In our case, in the case of redundant neural network, as we can bypass the weight function and have a much better classification process. So anyway, here's another example here of an ECG that is not normal. If you have that, you will not feel that your heart has a problem. You would still have the beats. If you compare that, let's say, the many technology that just look at arrhythmia, you will still see that the rhythm of the heart is correct, but you can see here that there are some anomalies here in the QRST complex. So using the algorithm that we developed, the RNN with basically 18 layers, we were able to classify 17 different rhythm type. These are the different rhythm. And we were able to get a normal, abnormal class accuracy of 97.7 or 98% with 2.7% alarm rate. So we can detect those things, and we can actually, so you can wear the device, and then we can detect. So for example, if you say you go up the stairs, or you run for a while, and then suddenly your heart is not working properly, we can actually detect that. And then what happened is this will be into the MedROAD system. And then what happened is the alarm will be triggered and the information will be sent to the GP or to the cardiologist, and you will have to look at it. He's the one doing the diagnostic, not the machine. And then basically from that, you can actually determine if you need to go to the hospital or some treatment that you might have to do. Another system that we're starting, this one is a brand new project, is one where we want to, and again related a lot to COVID-19, is a sensor called Healthcare Original. It's basically what it does, it's build a microphone with Bluetooth capabilities. The person can wear that on her chest or his chest. And then the idea is the same as for the heart. We have a lung sound, and then we have either normal or abnormal. And in the normal sound, we can have bronchial sound, vascular sound, vestibular sound, and tracheal sound. So we can actually, and those are normal sound. And but we can also, but one of the things that we can do with normal sound is, of course, we can detect if you're taking your medication. Are you taking, for example, your Ventolin as you're doing that? But for the abnormal sound, we can determine, that's very important for COVID-19. We can detect wheezing, rhonchi, and crackle. For a person who had suffered from COVID-19, at one point, maybe the 5th day of COVID-19, my lung was sounding like I was Coca-Cola. It was bubbling, and it was a very bad sign. And this is the type of thing you can track, and you can determine what level of lung infection you have. So we're in the process of using, for detecting those more complex signals, we're using bidirectional graded recurrent unit network. And then basically, same idea, you have your spectrogram of your capstrol, if you like, or spectrogram of your signal, and then you basically can classify it into the different classification that you want to detect. If you, we can do that, but we can basically combine that with heart and combine that with vital signs in order to actually get a complete picture of the patient. And actually this sensor, especially people who have, for example, go to the hospital, they have a COVID-19 condition, which means fluid in their lung. We can detect that with this without having to do X-ray or ultrasound. At the same time, we can, for example, leave the patient with this sensor and they can go home, and then we can determine if there is the conditions are getting worse or not based on that. So at the end of the day, we were thinking of what should we do in order for deploying MedROAD to COVID-19, but also deploying MedROAD for really its future. I mean, COVID-19 will go one day once we have a vaccine. And so how can we actually explode, if you like, the medical system in a sense of making it cheaper? And so one thing that we are in the process now is to deploy MedROAD into virtual clinics. Some could be in doctors, some that we are doing and now will be into pharmacies. So you go to the pharmacy, you're not feeling good, you say, oh, my heart, or my heart pinch. You will be measured there, you would get in contact with a clinician online, and you would get their test. Hopefully at the end is sufficient information for the clinician to give you some prescription possibly. And since you are already in the pharmacy, you can issue electronically the prescription and then get this information. So we are deploying that, one in a rural region, in a remote region, and also into in aged care facilities where basically nurse going to monitor older people. The latest project that we're working on is also the MedROAD mobile clinic concept, and this is really starting, but we have a collaboration with a group in France called Acute. And the idea is to have a bus like this where you would have a virtual clinic, and but it will do more than that. You will be able to do something that is the ability to have a robot do ultrasound, where let's say in the bus, a clinician will install the robot, the ultrasound machine close to where you want to monitor, for example, the lung, and the clinician would be in his office and at home, or in a clinic, in a remote clinic, and being able to actually perform ultrasound inspection of your lung, for example, in case of COVID-19, or heart. So be able to see, for example, the heart valve or activities in the heart that might have been confirmed. So the idea is to bring this type of technology, remote imaging with remote vital sign measurement and, for example, blood analysis, and then being able to have a complete virtual clinic that is on wheel, and then you can go into remote region or into poor part of town where there's no clinical monitoring. So one thing in order to do that, we've, with the Mazenkowski Heart Institute, Dr. Becker, and quite a few others, we've developed a special algorithm that allow you to take this robotic or robot arm and basically integrate multiple views of the heart scan, and then we can create equivalent of an MRI machine, if you like. We can take multiple views and then view the heart in multiple directions in order to get a better understanding of the heart condition. So what are the impact of AI and its and on medicine, but also on COVID-19? Well, AI has many ways to influence medicine. One of it is, of course, AI-assisted surgery. I didn't talk about that today, but it's certainly, as you can imagine, if you have a robotic ultrasound machine, you can also have robotic surgery. But the most important thing that will have an impact for the moment for COVID-19 is remote medical imaging and AI-assisted medical diagnostic. being able to do that will allow us to combine information, create patient-specific model. Not all patients are the same. There are some blood pressure conditions that are okay for some patients and are not for patients. So really, and being able to do that at home or into virtual clinic. So the impact on AI in healthcare is to leverage human labor by increasing its capacity, which is in COVID-19 critical. If we can monitor people at home and monitor safely at home as if you were in the hospital, we can take patients that come to the hospital, return them unless they're super critical and we need a ventilator. We can bring them back and of course reduce the usage of the hospital facilities. So when like I said, when AI is combined with continuous sensing, one can prevent and predict accurate medical conditions that like side effect of COVID-19. It certainly will help to improve COVID-19 diagnostic accuracy and monitoring as well. And of course, one of our main goals for MedROAD is to do cost reduction and to the cost reduction for healthcare system, as well as improving quality of care. So it's our belief that using such system, we can validate and track quarantine process using COVID-19. And why we want to do that? Well, there is unfortunately people are getting too anxious to be together, and we unfortunately might end up with multiple wave of this COVID-19. Certainly, if you look at the statistics around the world, we are still in the first wave for the whole world, and for many countries like the US, for example. Some countries like Canada, France, we managed to reduce it, or at least we passed, I think, the first wave. But there's no guarantee. People get careless, and we might end up. And in 1918, the Spanish flu infected 500 million people and basically killed 17 to 50 million people if we're not careful. Some British researchers have actually studied that without having people staying at home in Europe, the COVID-19 might have killed 3 million people. So in those days, they didn't have these capabilities and also the capability of monitoring. So it's certainly what we want to do is to avoid that second peak here to be worse than the first one. So a lot of this work is done in collaboration with the Faculty of Medicine in the University of Alberta, Alberta Health, and the Faculty of Science, and also with Cisco system that allow us to develop networking capabilities for this. You can imagine that if you wanted to start sensing, for example, even for quarantine, you might have millions of people you need to sense. It's low bandwidth, it's low information, but still you have to be able to sense all these people. And as part of our development as a Cisco Chair Healthcare, we actually started about last year. And go tell you that it's a bit brave, and we started a company in the middle of a massive depression, of a reduction in the economy. We started NIAID Lab, and NIAID Lab purpose is to commercialize what we've been presenting. That's it.
Yeah, just like what I said at the last of the presentation, you showed us that there is more pandemic waves coming.
Yes.
So I would really expecting that all the healthcare professionals and scholars make great efforts on, to let our people avoid those waves.
Yeah.
So
I was going to say, so one of the critical things to do is to be able to monitor when people start to feel the symptom and get into quarantine. First, to determine if they're doing the quarantine, being monitored during the quarantine, and at what level they are infected by measuring parameters. That's very important.
Mm-hmm. Okay. So here I have a quick question. So once we got symptoms collected by the sensors, using your MedROAD platform, how long we can trigger
COVID-19 test station, you usually
Yeah.
get a 3 to 5
So the
results.
Right. So the blood test will determine if you do have COVID-19 or not, but you don't know the severity. You just know that the possibility of getting COVID-19, and you also don't know if people are actually doing the quarantine. So one thing is very important is by showing to people that they have some of the symptom. It could be low symptom because there's a lot of people have low symptom. Of course, nonetheless, they are still very infected and can transmit that to. Unfortunately, it could go, for example, someone who's a cardiac patient or to grandma, to grandmother, which would be very sensitive to that. And so the idea is that by sensor monitoring, as opposed to blood testing, you can actually determine that. So, and it might be cheaper as well.
Yeah, that's good because by the sensor information, we can get the severity level, right? Exactly, that's right. Okay. Let's look at the questions that the audience give to us. Yeah, there do have a couple of questions here. So the first one is that will more advanced sensors or devices be implanted in the human body in the future?
That's the possibility that we can have in some way, for example, certainly temperature, certainly O2, and some of the heart monitoring could be implanted in the body. If you think about it, one group of sensors that are already implemented in the body is the cardiac, in the sense that if you have a pacemaker, you actually have a heart monitor as well. So you can actually, many pacemaker owners can actually download their heart data to an analyzer and then basically get analyzed. But in the future, it would be possible to have all this information downloaded and maybe just stay local and get analyzed by your cell phone. Cell phones are still quite powerful these days. And then it will tell you, well, maybe you should go see your doctor. There's something really wrong with you.
Okay, yeah, but that sounds cool. So usually how where do they put on the body? For example, for the heart?
Yeah, so basically, I mean, in the cavity, chest cavity, there's a lot of spaces. And but also it could be, for example, you can put it in your for
arm.
For example, you can put it on your blood, on your skin, and
wow.
All this has you would actually have a internal network that would actually send this information to your cell phone or your local computer, and then get monitored.
Okay.
Cool. It's possible. It is possible, and actually, quite a few people are working on that. So.
Okay, thank you. So let's come to the second question. In the field of aged care, do you think simulation robots with excellent performance will be more helpful in the future?
There's two things. Certainly, the robots and AI in general doesn't have general context. So if you like, we have the context of environment, social context, environmental context. So I always think that AI will always be there to help, if you like, the clinician to do his work better and do better diagnostic. But eventually, I mean, for example, for a surgeon, to help navigate, robot to help navigate, for example, in trepanation needles into the brain, help you to go into the right direction. And certainly a robot assisted with humans will always make a perfect pair. To have a fully automated robot, I would wait a couple 100 years to maybe take the risk of using them.
Couple of 100 years.
Yeah, I think so, because as you may know, I'm a developer of this technology. Things can always go wrong with computer. So is human. I mean, human can go wrong too. But the big difference is doctors, especially surgeons, have been trained for 10 years, minimum 10 years, to reduce their error rate. And so you could do that with computers, but certainly But the other argument for that is that it's legal. If something goes wrong with a patient, and you cannot sue a machine. So you cannot go to court saying the machine made an error. It has to be a human to actually look at the data and make the diagnostic. And if he makes a mistake, let's say he tells, well, the computer told me that this is the reason, then he's going to be the one responsible for it. Because without responsibility, things get very dangerous. That's it.
Mm-hmm. So I think the reliability of those kind of AI equipment becomes more important, right?
Yeah, well, certainly reliability, certainly for being able to monitor long period. I mean, doctor cannot do that. Monitor long period of complex signal, let's say your O2, your glucose, your heart rate, and so on, and put all this together into a patient-specific model saying, well, from what I see there for over 2 weeks, there's something really wrong with your body. And so it's up to the doctor. So what's important is that the AI is able to explain in human language why it thinks this way and explain it to the doctor, and then the doctor can validate that. So
yeah, exactly. Yeah. Okay. The third question is that many senior citizens cannot use smartphones, so they need their relatives' help to use your app. So how many person registrations can one account contain? This is really
so it is actually indeed an issue, and we have another device which is a small. It's not a cell phone. It's actually just a device that reads the data, and you plug that into your network at home. And as soon as the senior patient or you as a grandson or a son make the measurement, it automatically goes to the cloud. So you have nothing to touch, and you don't have to have a cell phone. The only reason you need a cell phone is when you go outside. But when G5 will come out, then there will be the possibility that the device itself would transmit to the G5's network automatically. So, but currently we have a cell phone that transmits through LTE the information to the cloud. So we need a cell phone, but in the future, we might not need a cell phone. We just simply have a device that can send signal to the G5 network.
Okay, yeah. But it is the challenge for the senior people. Yeah,
it is.
Rely on the cell phone, smartphone.
We actually, when we do deploy our system to old age home, we don't use cell phone. We actually use that little hub. That's it. That's it. So they don't have to do any of this. That's it.
Good. Okay. Thank you. So the first question is that I wonder how many patients have tried these devices during this pandemic? Do they report significant improvement in terms of the diagnosis process?
Yeah. So we've tried for the quarantine one. We've tried 40 patients that had that, and then we are now into planning to try another 40 patients with the sound monitoring system, and so this is the longest part. Is to develop the technology is one thing. The other thing is we have to associate ourselves with doctors that are willing to do clinical trial of our system, and of course during the COVID-19 there were some problem in the sense that many doctors were busy at the hospital with COVID-19 patients. So it's starting now. It's part of as we've experienced what the pandemic can do. How can we come up with new tools that will allow to next time, if we have a next time, can we do better than what we did? So we are doing clinical studies. One for a remote clinic in rural Alberta. We also doing an old age home monitoring, and then we also doing some, like I said, for quarantine and also for extreme case of COVID-19 for patients who had cardiac or respiratory problem. But those take a year to 2 years to do testing.
I see. Yeah, it really takes time usually.
Yeah. Okay.
And another question coming, he asked, just out of curiosity, if implementing the monitoring devices in an ambulance, is there any reconfiguration required for the ambulance?
So no, not really. I mean, we tried with ambulance using the device, and as long as you have a good LTE connection, which we do in Alberta, we have a very good LTE connection, there is no issue. The data get transmitted. And if we have a blind spot, let's say there's no LTE, the device will accumulate the data. And as soon as it sees a network, it will transmit the data to the cloud. So the accumulated data to the cloud. So, so we took into account that the fact that we have a good LTE. And if you're, let's say, in a very remote region, let's say in the very north of Canada, you, of course, we can also connect to satellite link. So there's quite a few services of satellite internet that actually is not expensive and allow you to connect this way. So.
Yeah, satellite will be a very efficient way.
Yeah, that's right.
Yes.
But there are some regions. For example, I tried to do that in the Rocky Mountain here, and of course, if you're in a rocky or in a very mountainous region, you might not see the satellite, and then so so there is always condition. On the other hand, like I said, G5 will change all this, and where it will basically allow to have internet everywhere. So
yeah, it does. G5 will change our lives significantly.
That's right. and actually, one of the big application of G5 would be remote monitoring of patients.
I agree. Yeah. Okay. So I think the last question it would be mine. So I just wanna be on behalf of all the people who are curious about AI. So could you give us some examples that, as we watch your presentation, there are 10 ways AI is transforming healthcare. So now, in what way that healthcare professionals cannot be replaced by AI? Just
So
some examples there.
Yeah. So one of the big things, I belong to the Department of Radiology, and AI is making a huge revolution in radiology. The problem is more and more GPs and other doctors are requesting to have medical imaging done on patients. And so the workload on hospitals is getting bigger and bigger. What happened is with AI, what allow you to do is to do a CT take not even 5 minutes, 10, maybe less, 10 minutes, let's say, with patients sitting down. So the problem is, of course, you need to have an individual that is very highly paid to actually look at many of those slices and determine, well, okay, I can see here there's a small tumor that is growing. With AI, what it does, and actually in China, you've done an experiment where you had 200 radiologists and one AI to look at X-rays, and the AI won.
Oh, really?
So, yeah. And the reason for that is, you can imagine, if you're a radiologist and all day you're looking at images and you're trying to detect tumors, it's after a while, it becomes quite boredom, and also you get tired. The advantage of AI, it doesn't get tired, but also what it does is, for the radiologist, it becomes another tool they can use in order to detect that. So the AI will say, hey, I think there's a tumor here. It might be false, but it might be true, depending on the context. But the radiologists only have to look there instead of looking everywhere. So, so it's a way to streamline the work in some way, to accelerate the work of a radiologist. And that happened to many other things in other fields where AI will allow you to monitor people as they're doing their daily life, and and a lot of disease show up in daily life. You might have I don't know, grandpa drank a little bit too much wine. He ate some too much food, and suddenly his heart is doing some funny thing. Well, I mean, maybe you should go on a diet or avoid wine, but, you know, or it might also indicate that his heart has a problem. But if you don't continuously monitor like this for people who are older, for example, what happened is you will never detect that. And then suddenly the person will die of heart attack and you don't know why. When you could have detected that earlier, save a whole pile of money to the healthcare system in order to detect earlier the heart condition. And maybe at that time, if it's early, it could be a matter of doing a bit more exercise and doing some better diet. So continuous monitoring combined with AI will allow you to do that. So it's
continuous monitoring.
Lifestyle. Yeah, that's right.
So I think the sensor will be the huge area that.
Yes, that's right. Sensor mixed with the ability to recognize. Sensor by itself is just data. What you need is a smart analyzer of the data that allow you to detect conditions. That's yeah. But it is certainly, I think it's a lot of future to, as population, especially population aging significantly, pretty much everywhere, we're going to have to monitor people, especially if we want to have people staying more at home, and instead of going to an old age home, you can stay safely at home if you are monitored.
Yeah, right. Okay, so we cannot, keep asking the questions because the time passes so quickly. 1 hour goes to the end. So the audience are encouraged to get in touch with Dr. Boulanger or us organizer to know more details that you are interested in. So thank you very much, Pierre, for today's impressive presentation. And thank you everyone who attended the meeting. So it's time to say goodbye. See you next time, next webinar. Okay, so bye-bye. Have a good night or have a good morning. Have a good day in China. All right, bye-bye.